Welcome to medication orders. The first thing we need to discuss when it comes to medications is, as nurses, we must have an order to give a patient medication, even if the medication is over the counter. In addition to the fact that nurses do not have the scope of practice to order medications, having an order from a provider helps ensure the safety mechanisms in place to prevent errors. The safety mechanisms include the provider's knowledge of diseases and medications, the pharmacist who checks the order for accuracy, the pharmacist or pharmacy tech who dispenses the medication dispensing machine, the EMR, and us, the nurses who administer the medications. Having an order to give medication even exists for patients' own medications from home. They cannot take their own medication supply unless a provider writes an order to do so. Even then, the facility may not allow it. It really depends on the facility's policies. There are a couple types of orders providers can choose from. The first type is standing or routine orders. These orders are usually facility-based orders for all patients or all patients on a certain type of unit. The provider can choose what orders they want from a list. There are single one-time orders. These are orders given for a specific reason, like adding a medication to the orders that are already occurring. Then there are stat orders, which mean they need to be completed immediately, typically in an urgent or emergent situation. Then we have PRN orders, which means they are completed as needed and must have a reason why they can be completed. The last type are prescriptions, which are medications that are to be taken outside of the hospital, like at home. When patients are admitted to a facility, the nurse must do a home medication reconciliation. This means the nurse writes down all of the medications currently being taken at home, their dosages, routes, and frequency, and last time the doses was taken. This becomes a part of the orders, and the provider will choose to continue the medications in the facility or stop them. When we compare our MARs to the orders, we need to look at this form as well to make sure we have all the medications ordered by the provider. The home medication reconciliations are required and are an important part of patient safety. If we do not have a list of the home medications, we do everything we can to get one. And you never know, the home medication may be the cause of the issue that brought the patient into the facility in the first place. When a provider enters a medication order, there are specific things that must be present. The EMR makes this process much easier as it fills in some of the information for the provider, but you need to know what must be present. We must have the patient's name and date and time of the order. We must have the medication name and dose, and depending on the medication, either the generic or trade name may be used. Sometimes they might have to write brand necessary to make sure the patient does not receive a generic equivalent. The route and the time or frequency must be included. If the order is time limited, such as only give for 48 hours, that must be included as well. If the medication is PRN, meaning as needed, the reason for that PRN is required and must be specific. For example, pain medication is often ordered PRN. PRN pain medication will say PRN for pain levels 1 to 3 or PRN for pain levels 8 through 10. It's a very specific reason. The last thing required for medication orders is the provider's signature. If this is EMR, it will be an e-signature. If any of these elements are missing, the pharmacy will not be able to fill the order and patient care may be delayed. Once a provider has written an order, it goes to the pharmacy for processing and it goes to the nurse to write on the medication administration record, the MAR. In the EMR world, this automatically occurs after the order is e-signed. The pharmacist accepts the order and then it flows directly to the medication administration record for the nurse to see the information for administration. In downtime or paper charting world, the order will be sent to the pharmacy, usually by fax, and the nurse must handwrite the medication on the MAR. The order gets copied word for word on the MAR, and then the nurse signs off the order on the order sheet. Signing off the order is telling everyone that the order was seen, written on the MAR, and will be carried out. To sign off an order, you're going to follow your facility's policy, but it typically involves writing noted, the date, the time, and your signature and credentials. The pen color is dictated by your facility, but red ink is pretty common before EMR. So let's take a look at this example. The first line has the order, and the second line says that it has been noted by the RN. In a perfect world, the provider would write down all of their own orders and the nurses would never have to get involved. However, the world is not perfect. Therefore, there are times when nurses need to write down the orders for the provider. Please follow your policies for when this is allowed. To take a verbal order, the order must be given directly from the provider to the nurse. It cannot be from provider to someone and then to the nurse. It is direct communication. The nurse will write down the order and read it back to the provider. This readback is very important to make sure the nurse heard exactly what the provider said. When entering the order to an official order sheet or into the EMR, the same rules apply for when it was required for the order. Patient's name, date, time of order, medication name, dose, route, frequency, and then we add the method we received the order. VO stands for verbal order, which means you would be taking a face-to-face communication. TO would be for a telephone order, which means the order was given over the phone. You may also see VTO, which means verbal telephone order, which just means the order was given verbally over the phone. After the method for which the order was received, you add RB for read back. Then the provider's name and credentials and your signature and credentials. Depending on your facility's policy, providers have 24 hours to go into the chart and physically sign the order. In the downtime paper world, it would be an actual signature. In the EMR world, it would be an e-signature. Having the order signed by the provider afterwards ensures the nurse ordered things correctly and is not falsely writing orders. The next several slides list out the common medication-related healthcare abbreviations you will see. Due to EMR, most of these abbreviations aren't used, but if you ever go to downtime or work somewhere without an EMR, you need to know these abbreviations. Some of these abbreviations have been deemed dangerous and cannot be used. Due to the potential for medication errors, the National Coordinating Council for Medication Error Reporting and Prevention and the Joint Commission recommend that any STARD abbreviations be written out in full. One reason for this change was the abbreviation for morphine. We used to write MS or MSO4 for morphine sulfate, but magnesium sulfate was written MgSO4 and people would often get the wrong medication, a lot. Healthcare workers were well known for terrible handwriting, and in situations like this are why. We must also be careful when we write out dosages. No trailing zeros for whole numbers like 1.0. We must also put a 0 in front of a decimal that is less than 1. We have to write 0.1. Here's a list of the most common types of routes you will see and their abbreviations. Notice how many have stars, meaning they're not safe for orders. We must write out those abbreviations to be allowed to use them. This is for patient safety. Remember, everything used to be handwritten and it was very easy to mistake things like OD and AD if the handwriting wasn't perfectly clear. These are the days that I am very thankful for EMR because handwriting is not my specialty. Here are some of the common abbreviations for the amounts of medications or dosages. America as a whole uses the imperial method for amounts, teaspoons, tablespoons, cups, gallons, etc. But healthcare in America uses the metric system, milligrams, grams, milliliters, etc. So you must be able to calculate the difference between the two. Notice how that U has a star? We cannot use U. We have to write out the word units. There's an old term sometimes used in textbooks called grain or GR. This term is outdated and is part of the do not use list, so you should never see it being used. Here are the common abbreviations for timing of medications. Notice HS has a star. HS can mean half strength or hour of sleep. DC also has many names in healthcare, so we don't use that one either. I once received an order that was on paper from a doctor that said DCAC, just those 4 letters. It took every nurse on the unit and a phone call to the provider to figure out what that order meant. That could have cost the patient their life. With and without are probably my favorite abbreviations, and I use them in my own personal life. Both of them would be written with a little horizontal line over the letter on top of them. Here are some of the standard abbreviations for timing, and if you notice, pretty much all of them are starred. It's very easy to misread the Q in front of some of these times. That's why they're on the do not use list. They really prefer that we would write out like every 4 hours or every day. Some people will still use the Q, but we should not be. It's pretty dangerous. And this brings us to the end of part 1 of medication administration.